Hello, my name is Mary Mitchell, and I will be doing my webcam presentation on a 20-year-old Hispanic male that came in for a traumatic brain injury. So his history of present illness. This is a 20-year-old Hispanic gentleman that was involved in an autoped hit and run. He suffered a traumatic brain injury. The driver was going approximately 45 miles per hour when he struck him. On scene, he was found to have a GCS of 6 and he was intubated. He was transferred to our hospital for trauma services. His initial CT of the head showed scattered subarachnoid hemorrhage, frontal contusion, questionable pontine hemorrhage, and an occipital and basal skull fractures. He also did have a CTA of the head and neck, and that showed a questionable right carotid artery dissection or pseudoaneurysm. He did have a cerebral angiogram, and it ruled out the carotid artery dissection or pseudoaneurysm. When I saw him, it was his second day in the ICU. He had no medical or surgical history. He did not drink, smoke, or use any illicit drugs, according to his family. He actually had 2 jobs, one of which was a lifeguard. That's why he was on the island. This happened at South Padre Island. And he was planning on attending college in the fall. He had no known allergies. He didn't take any prescription or over-the-counter medications. Review of systems, I wasn't really able to obtain because he was intubated, but you could see that he had obvious abrasions to his face, arms, leg, and back. So physical exam. He's a Hispanic male. He was well nourished. He appeared to take care of himself. Vitals were as follows. Temperature was 98.3. Respiratory rate was 18. Heart rate was 90. Blood pressure 143/69. Oxygen saturation was 100%. His ICP was 21 and his CPP was 72. Lab findings, sodium of 158, osmo 322, potassium 3.4. His CO2 was 29, BUN 12, creatinine 0.78, MAG of 1.6, WBCs were slightly elevated at 12.4, H&H was stable 11.5 and 36.9, platelet count was 155, coags were good, PT 15.2, INR 1.17, PTT 28.6. Neurologically, he was intubated and sedated. He was on propofol, Versed, and fentanyl. His pupils were 2 millimeters bilateral, but it was hard to appreciate if he had a reflex. He did have a weak cough to stimulation, but no gag. He was flaccid to all 4 extremities to deep noxious stimuli. He had a EVD on the right side. It was 10 centimeters above the tragus. 24-hour output for that was 280 mLs. It was blood tinged. ICP range for 24 hours was 6 to 30. Currently, it was a 21. Cardiovascular, S1, S2 were appreciated. There were no murmurs, gallops, or rubs. Respiratory, he did have a weak cough to stimulation with suctioning. His lung sounds were clear to the apices and diminished to the bases. No rhonchi or rales were appreciated. He was on the ventilator. It was a 6.5 ET tube, 26 centimeters at the lips. Assist control, volume control. Tidal volume setting was 500. Respiratory rate was 18. He was not breathing over the vent. PEEP was 5 and FiO2 was 30%. He did have an OG tube in place, but we hadn't started feedings at the time. He had a 16 French Foley in place, clear yellow urine, musculoskeletal, a 0 out of 5 strength to all extremities, but he didn't have any loss of range of motion. And then integumentary, like I said, multiple abrasions on his face, his arms, his legs, and his back. So my assessment was obviously number 1 was the traumatic brain injury. Number 2 was cerebral edema. 3 occipital and basal skull fractures. 4 acute respiratory failure secondary to the traumatic brain injury. and then 5, the leukocytosis with the slightly elevated WBCs. So my plan for him was to continue the neurochecks Q1 hour, report any decrease, any changes. Kind of hard to appreciate any decrease, but any changes in pupils. Did he, if he lost his cough since he didn't have the gag. We'll continue with the EVD to be at 10 centimeters above the level of the tragus, monitor hourly ICPs, and report any elevated ICP greater than 20 for greater than 10 minutes. Since we were having the issues with ICP over the last 24 hours, we did decide to order a 6-hour EEG, and we were going to stop the propofol infusion and switch him over to Nimbex. We did get this cleared with the trauma services, but before starting the Nimbex, we wanted at least 45 minutes worth of EEG to see if there was any sort of seizure activity that wasn't apparent, and then we were going to go ahead and start the Nimbex. We did change the systolic blood pressure goals to 120 to 180, but the goal was not really blood pressure, it was to maintain a CPP above 70, and we could start Levophed if needed. At the time, though, his CPP was 72, so we were within range. We were going to continue the hypertonic saline for a high goal sodium level of 145 to 158 goal. Continue mannitol 0.5 grams per kilo Q6 hours and hold that if the serum osmo goes greater than 330. Check serum sodium and osmo levels Q6 hours. Continue Keppra 750 milligrams IV BID for seizure prophylaxis. Continue Rocephin 1 gram IV Q24 hours. Keep the patient normoglycemic, euvolemic, and normothermic. Repeat CT of the head if there were any changes in his neurologic exam. Bilateral STDs for his DVT prophylaxis, and Protonix 40 IV daily for GI prophylaxis. Thank you.